Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Vida Reed. Vida graduated from George Mason University in 1995. She has worked for many years as a research nurse in the area of women's health, heart disease, and diabetes. She became a certified diabetes educator in 2001. She is a member of the American Association of Diabetes Educators and the American Diabetes Association. Vida has been at Washington Hospital since 2006, serving as our diabetes program coordinator.
The history of diabetes. I have to tell you, it was very interesting. I learned so much with researching for this talk, and there is so much that I didn't put in. There's so much to know about diabetes and how it all started and everything. But I think if you get anything tonight, I want you to understand how it is, not so much how complex it is, but the work and the effort that is going into and has gone into finding a cure for diabetes, or initially identifying what exactly it was, and then finding a treatment, and now the race continues to find a cure. So it's come a long way, and I just hope you guys can appreciate the information. So before we do get started, let's talk about what diabetes is. It is a metabolic disorder resulting in abnormally high blood sugars called hyperglycemia. So your blood sugar levels rise. Blood sugar is controlled by a hormone secreted by the pancreas called insulin. So when you have diabetes, you have no insulin production, or you have limited insulin production, or you don't use it well. So diabetes is a condition that causes your blood sugars to rise too high because you don't have the insulin to control your blood sugars. All right? So that's what diabetes is. The earliest known records about diabetes were found in a 3rd Dynasty Egyptian papyrus. And what they wrote in there, it mentioned a condition with symptoms of frequent urination and the cause of emaciation. So that's what they noted. They didn't have a name for it, but they noticed that people were urinating a lot and they were wasting away. Ancient healers also noted that ants were attracted to the urine of people with this mysterious disease. And also around 500 BC, it was noted that sugar in the urine and its occurrence in obese people. So they started to attach this diabetes things to people who were obese as well. And so it began. In 150 AD, a Greek physician described what we now call diabetes as the melting down of flesh and limbs into urine. It was from this time that we started to gain a better understanding of what this disease was. Around 250 BC, the term diabetes actually came out. It's a Greek word meaning to pass through or siphon. Apollonius of Memphis is credited with coining this term. It was a disease that drained patients of more fluid than they could consume. So the whole urine thing. Have you guys heard about the symptoms of diabetes that we focus on now when you're undiagnosed or untreated? Excessive urine, excessive thirst, excessive hunger. So this is what they were starting to see in these patients. But how did those kidneys get involved? Early on in 164 AD, diabetes was diagnosed as a kidney ailment. So they knew then that there was something happening with the kidneys when these persons had diabetes. And I'm sure it had to do with the urine, the excessive urination that patients were experiencing. But the kidneys were listed as a result of the diabetes. Other historical facts. Around the 11th century, the Latin word mellitus was added to the term diabetes. Mellitus is a Latin word for honey, and it was added to the term diabetes. So now we have diabetes mellitus. And in the 16th century, diabetes mellitus was identified as a serious disorder. Around 1776, they also noted that a brown sugar-like substance was noted when the diabetic's urine evaporated. There was a brown substance that was left behind. And they noted that when the blood of persons with diabetes was tasted, it was a little sweet. And they also began to make the distinction between type 1 and type 2 diabetes. They noted that in some persons, the condition was fatal in less than 5 weeks, and for some people, it was a chronic condition. It continued for a long time. And in 1778, they noted that the excess sugar was also in the blood, not just in the urine. It was also in the blood. So how did they test for this disease early on? What did they do? Well, one of the things they noted, as we mentioned, is the excessive passing of urine. They noted that ants were attracted to the urine of persons who had this condition. And they also had what they call water tasters. Water tasters were those people who tasted the urine of people who had this condition, and it was sweet. Water tasters is what they call those people. In the early 1800s, the first chemical test to indicate and measure the presence of sugar in the urine was developed. So imagine if this was how we still tested for our diabetes, right? Fortunately, we've moved on to something more modern. So here comes the liver. Because as you guys know, if you have diabetes now, your doctor probably talks about things like protecting your liver, your kidneys, your hearts, and everything. Very early in this race to identify what this disease was, they found that glycogen stores formed in the liver. So this was the first linking of diabetes and glycogen metabolism. So the sugar that's made from the liver and diabetes were starting to get connected and linked at this point. So they're putting together the pieces of this puzzle about what this disease is. And when they actually had identified, now remember we call it diabetes mellitus now, early treatments were pretty archaic, or maybe not, because some of these things are still tried today. The high-fat, high-protein diet was implemented after it was noted that the urine increased after eating starchy foods. So they noted that people, when they ate food and they had more starchy foods in their diet, that they had more urine, right? So they felt, well, let's give them a high-fat and a high-protein diet. In the 1850s, the patients were advised to eat extra large quantities of sugar, because obviously if you're losing sugar, then we want to add it back in, because maybe this is something you need, and the loss of it is why you're having the ailment. So they advised patients to have large quantities of sugar. This was the first, but not the last time that this would be tried again in the future. In the 1870s, food rationing in Paris during the Franco-Prussian War, it was noted that the sugar in the urine disappeared. So they were having basically food rationing. People weren't eating as much, and they noted that the urine and the sugar disappeared at this time. So this led them to understand that people needed individualized diets for managing this condition. They discovered that one size does not fit all. As time goes on, they continue to look at very strange ways of treating this condition. We saw the oat cure, which was 8 ounces of oatmeal with 8 ounces of butter eaten every 2 hours. There was also the overfeeding. Remember, I talked about the excess eating more sugar. To compensate for the loss of fluid and weight, there was something called a milk diet, the rice cure, the potato therapy, and even opium was used to treat this condition. Frederick Madison Allen, he was a very important person in the development of treatment for diabetes, although his critics didn't like him very much. He wrote a book called The Studies Concerning Glycosuria and Diabetes. And in this book, he advocated for the starvation diet, a very strict diet regimen. And he would admit patients to the hospital who had this condition called diabetes, and they would be given whiskey mixed with black coffee, clear soup for teetotalers, fed this every 2 hours from 7 a.m. to 7 p.m. until there was no sign of sugar in the urine. This usually took about 5 days, followed by a very strict diet. Many of his patients died, likely from starvation, but he attributed the failure to the patient. The patient didn't do what he told them to do. They didn't do it right, and that's why they didn't succeed. Have you guys heard that from your doctors before? If your doctors blame you for why your diabetes is poorly controlled, right? But, you know, he was a leading specialist at the time. But what he did is he stimulated a revolution in therapy, and he was supported by some of the top specialists at the time in terms of treating diabetes. His critics thought he was heartless and cruel. His biographer said he attempted to exercise control over his patients in his laboratory like animals. There was another guy who was pretty instrumental around this time. His name was Elliot P. Joslin. Has anybody heard of the Joslin Center in Boston? It was the first center in the U.S. that came about to look at a cure for, research for, and treatment for diabetes. Dr. Joslin, his key to managing diabetes lay with the patient involvement, and that had to do with education and empowerment. So that was his theory. He believed that diabetes was the best chronic illness you could have. It was clean, seldom unsightly, not contagious, often painless, and susceptible to treatment. And so he wrote a book called The Treatment of Diabetes Mellitus, and it combined the fasting diet that the other guy had put together with regular exercise. And so Dr. Joslin created the Joslin Diabetes Center, and it is still around today in Boston, and it's one of the leading centers for diabetes research and treatment. And these principles that he introduced here are still kind of what we follow today in terms of diet and exercise and education. But even with all of this, diabetes still led to a premature death at this time. The leading causes of death in 1900 versus 2010, as you can see, they've changed a bit. In 1900, diabetes wasn't listed as a cause, but as you can see in 2010, it's about 22.3 deaths per 100,000 persons. Life expectancy before and after insulin was developed is pretty startling. The average age of death in 1887 was about 58 if you were diagnosed with diabetes at 50. If you were diagnosed at 30, you lived another 4.1 years. If you were diagnosed at age 10, you actually only lived about maybe a little over a year once you were diagnosed with diabetes before insulin was developed. Once insulin was discovered in 1921, people over the age of 50 gained about 8 years to their life. Those at 30 gained about 26 years. And if you were 10 years old when you were diagnosed, you gained about 34 years of life once insulin was developed. Insulin is a pretty important hormone in controlling diabetes, as you can see how life was extended. Life expectancy in 2004 is still lower, and that's the most recent data, is still lower than general population by about 15 years for persons who have diabetes. So what about insulin? Well, there were some breakthroughs that started to happen. There was a researcher in France who showed that the removal of a dog's pancreas could cause diabetes. It says could cause insulin, but could cause diabetes is what that should say. There was a German scientist that found that injecting pancreatic extract into patients could help control diabetes. That went largely unrecognized at the time that it happened, but later it became a very important finding, although this guy didn't get much credit for it. A Romanian scientist published an article describing his successful isolation of the pancreatic insulin. Again, this guy didn't get a lot of credit for what he found either, because later the other guys kind of took credit for all of this. And I also wanted to note that, as you can see, this race to find a cure for, a treatment for this condition, it spread across countries. They were looking at this all over the place. So this disease was happening everywhere. It's not, I know a lot of times people think it's an American disease, but it's really not. It's been around for a long time, and it's everywhere, all over the world. And at this time, people were really looking at this condition to try to find a cure for it everywhere. The discovery of insulin was one of the most dramatic and important milestones in medicine when it happened. The doctor by the name of Frederick Banting of Ontario, Canada, he began to experiment with the different pancreatic extracts of depancreatized dogs. So they literally removed the pancreases of the dogs, and he began to experiment with those pancreases. He was able to successfully treat one of these depancreatized dogs with the extract that he was pulling from the pancreas of the dog, a healthy dog. He was able to treat and successfully save that dog's life. They called that dog, some of the research says his name was Marjorie. Her name was Marjorie, the dog that led to the cure for diabetes. And so once this happened, things began to move really, really fast, at a very fast pace at this point. There was also some help with banting from a couple of guys, Collop and McLeod, a chemist and a physiologist. What they were doing was working to find a more purified form of this extract that they were using to treat diabetes. At this point, they didn't call it insulin yet. They called it insulin later. But they were working to create something that was more pure to use in real humans. These guys, they actually got a Nobel Peace Prize for this. Banting was given a Nobel Peace Prize, and so was Bess. And they shared it with their colleagues, McLeod and Collop, because they also helped them to find this cure. So the first person treated with insulin was Leonard Thompson. Leonard Thompson got his first injection when he was about 14 years old in 1922. He had an allergic reaction to it, and his treatment was actually considered experimental. And that was part of the reasons why they needed to find a more refined, a more purified form of it, because he had a really horrible reaction. But they worked to do that, and about 12 days later, he got his second injection. He showed signs of improved health. He went on to live with insulin for another 13 years before he died at the age of 27 of pneumonia. So he didn't die of diabetes, he died of pneumonia. He lived another 13 years with taking insulin. And he was the first person to receive insulin. And that was done in Canada. The first U.S. patient was a lady by the name of Elizabeth Gossett. Mrs. Gossett was the daughter of a U.S. politician, Charles Hughes. She was the first patient in the U.S. treated with insulin. She developed diabetes in 1918. She was 11 years old. In the spring of 1919, her mother took her to a clinic where she was to stay to be treated for diabetes. And they kept her there. She was put on a very strict diet. She was monitored for her condition over the next 3 years, and she lived there away from her family. This is a picture of her with her nurse who helped to take care of her at this clinic. She was about 4 feet and 11.5 inches when she developed diabetes, and she was fed a diet of under 800 calories a day. Her weight fell to about 45 pounds by August of 22. She was essentially wasting away despite this treatment. So in 1922, her mother had, everybody had heard about this insulin thing. There was a Nobel Peace Prize coming up for it. And it was a talk of the research community everywhere, hospitals, doctors. Everybody was talking about this extract, this insulin. So her mother, they had considerable power. Her father was a senator. So her mother contacted Dr. Banting in Canada and asked him if he would take her on as a patient. And he said, well, yes, I will. I'm sure there was money offered. He said, yes, he would. And so she arrived in Canada in August of 1922, and she started to get insulin from Dr. Banting. Receiving insulin, she rapidly recovered. She started to consume a diet of about 22 to 2,400 calories a day. Within 2 weeks, she went on to live until she was 73. And here's some other things that I thought were really important about Elizabeth's life, because she got insulin at a time when people were dying. She graduated from Barnard College. She married and had 3 children, 2 daughters and a son. She hid her diabetes from her friends and associates as she got older. It was something that she was ashamed of, even though at the time when she got the injection, it was a big deal. The news talked about it. But she destroyed most of the materials that documented her treatment. She removed all references to diabetes from her father's papers, in his biography and everything. She died of a heart attack April 21st, 1981 at the age of 73. She received over 42,000 shots of insulin before she died. But she lived a long and rich life on insulin. So now we've got this insulin thing coming about, and they need to find a way to mass produce it because at this time, it's very expensive to make it. They can only make it in small batches, and only people who had a lot of money could afford it. If you didn't have money, you couldn't afford the insulin. Does that happen now? Yeah. So they needed to find a way to mass produce the insulin, and in came this company called Eli Lilly, which is still around today, and I think it's up the street in Alameda. They came along and they were going to figure out how to mass produce this insulin. In the meantime, there was a lot of stuff happening around insulin itself. Who was getting credit for it? Who was being rewarded for it? Who was being written in the papers? If you know anything about researches, getting published is a big deal. It still is. It was then and it is now. And so there was a lot of fussing and fighting happening and people walking away and feeling like others were taking credit for what they were doing. Banting started drinking. He wasn't paying attention to his lab. He said he thinks there was one night he went to sleep sober. Eli Lilly took it on. There were many problems with production, with purity and quantity. When they tried to go from small to large-scale production, there were just problems. There were variables that they didn't anticipate that came up in terms of how much of this do you use to go with that. There were just many variables that introduced themselves that they had to continue to work out to try to figure out how to get this drug mass-produced. But they did, and so how did we get that drug into you? Well, syringes were a really important invention to get insulin into you. And the origin of syringes probably lies in, those weapons like blowpipes and poison-tipped darts. So they knew they could get something into you through your tissue if they were to get something sharp into you first, right? So in 1807, they described a syringe as a well-known instrument serving to imbibe or suck in a quantity of fluid and afterwards expel the same with violence. Do needles hurt that much now? Anybody using needles, does it feel like that? When I see patients initially, that's exactly what they feel we're going to do to them when they have to use syringes. And this is exactly what they think. But okay, so the first uniform syringe was developed, which was important in 1944 because now they could actually measure how much you needed because it was individual, how much everybody needed, which also helped to further the development of the drug and also to treat patients. The syringes before that, they were all metal or some kind. You had to boil them, reuse them, sharpen your needles, all of those things. You didn't, throw them away. But in 1946, they got the first glass syringe. And in 1924, Becton Dickinson, which is a big company still around today, introduced the first insulin syringe, and it was a glass syringe. And in 1956, they issued a patent for the first disposable plastic syringe. So before that, you had to boil that glass, reuse it, sharpen your needle, all those kinds of things. BD is still the world leader in the production of needles and syringes. And when they introduced that first glass syringe, it was heavy, difficult to hold, required you to sterilize it between injections. And so, like I said, in 1961, they did develop a disposable plastic syringe. It was easy to use, it was lightweight, and you could throw it away. And this was great for people who needed multiple injections. I know that we think of diabetes as being very, very, very a busy activity. It takes a lot of time to manage it. But imagine you needed 4 shots, you got to sterilize that needle between every shot, right? This is a picture of an old insulin kit. It's actually one of the first insulin kits that Lilly developed. So you've got your insulin there, and you've got your needle and your syringes there. So it was one of the first ones they developed. So we know that they used to taste the blood and taste the urine to detect whether or not there was sugar presence. And all they were tasting for at that time was the sweet taste, the presence of, how much was there, how long it had been there. None of those things were known. So there was a kit that came about, it was called the Clinitest. It had precise instructions. So this is how you tested your blood sugar back then. You mix 10 drops of urine, so you got to get 10 drops of urine, you got to catch the urine, and 5 drops of water into a test tube, and drop in a tablet which made the urine and the water solution start to bubble. And then it would turn different colors. Depending upon the color of the solution at this point, determine where your blood sugars were at. If it was blue, your blood sugar was normal, and so I'm sure everybody was hoping for a blue color. I can imagine little kids back then waiting for that to turn colors and hoping and praying for blue. Kind of like when you look at your meters now. You know, you're like, oh, please, please, please give me a good number. Is that something you guys do? I hear that from my patients a lot. If it was darker green, that was not good. And if it was brown, that was the worst. But this is how you tested your blood sugar back then. Time went on, and they came out with something called test tapes. With the test tapes, you could dip these tapes into your urine rather than having to use that urine chemistry kit that we just talked about. You could actually take one of these tapes and you dipped it into the urine. And again, they still use color. You had to match the color. And depending upon the color, it again told you the severity of your blood sugar at that time. No number still, just it was either good or really bad or maybe not so bad. And then finally, they came out with the glucose chem strips. Now, these used blood instead of urine. This was the first kit that used blood instead of urine. They were mostly used in hospitals because people really couldn't afford them or in doctors' offices, but they required a great deal of blood and very precise use. So if you didn't do it right, you'd have to do it again. And again, they still use color to determine your blood sugar, but the color now actually corresponded to a range of blood sugar. So we're getting somewhere right here now. So now you know if your blood sugar is if it's good, bad, or ugly, you have a number that goes with it. And the number was within 60 milligrams of the correct number. So it wasn't a perfect test, but it was better than what we had. So you'd get a range of like 180 to 240. So it was a 60 unit range of what your blood sugars were. But it was an improvement of checking your urine for sugar, right? And when you checked the urine for sugar, that told you what your blood sugar was hours ago. By the time it got through, the sugar got through your system and into your urine, that's what it was hours ago. But the blood was a more accurate reflection of what your blood sugars are right now. So they had some home testing that came about around 1925. Again, it was pretty complex. This is how they tested at home now. 8 drops of urine mixed in a test tube with 6 cc's of Benedict solution, which you had to get that from your doctor's office, like going to the pharmacy, I guess. And you had to put that tube in boiling water for 5 minutes. And these directions were really very precise. And again, color of the liquid indicated the results. If it was greenish, you had light sugar. If it was yellow, your sugar was a moderate level. And if it was red or orange, it was heavy sugar in your blood. In the 1940s, they came out with something called the Clin sticks. This allowed instant monitoring of your blood sugars, and you would dip the stick into the urine and then compare the color of that strip to the color on this valve, and it would tell you again what your blood sugar was. But it gave you a number. The range had shortened a little bit, not so much 60, but a little bit shorter than it was before. So a silly fun fact, in the 1950s, the specialists were still recommending against marriage for people with hereditary diabetes. So if you had diabetes, they were recommending you not get married. Despite the fact that Johnson had told them it wasn't communicable, you couldn't pass it on, but they didn't recommend you get married. Because I think probably at the time, what I suspect is that they thought that if you married and had children, it might pass it on to your children, right? So they said that you shouldn't get married. Diabetes before glucose meters. Come a long way. In 1970s, Ames came out with what was called the reflectance meter. It was only used in hospitals or doctor's offices. It was very expensive, but it indicated your blood sugar by a moving needle. So that moving needle would tell them what your blood sugar was. In the 1870s to 1980s, home meters were introduced by a company called Bayer and Roche, the glucometer and the AccuCheck. These names have actually become kind of synonymous even today with a meter. Patients still ask for a glucometer. And when they asked for a glucometer, they would get the Bayer meter, but that wasn't what they wanted because the name had just become synonymous with glucose meters. So now we try to say glucose meters instead of glucometer. In Britain, a patient's result is called a BM. Patient is taking a BM. Mrs. X's BM is 5 because the company over there that developed the glucose meter was Boehringer Mannheim. So that's why they called it a BM as opposed to a AccuCheck or a glucometer, right? Between 1993 and 2005, glucose meters were kind of really infiltrating the market for home testing. This is a picture of like 4 generations of glucose meters of their time. The sample size for these meters could vary from 30 to 0.3 milliliters, and you can see what that looks like. If this is 0.3 and that's 4, and some of these meters require 30 units of blood to do a test. The meters on the market today require less than 0.3 to get a good test. And also they had to get what they called a hanging drop. So you had to get a really big drop of blood. It had to be hanging before you could drop it on the strip to get a result. But that was then. Time went on. Glucose meters today, they're small in size. The sample size is very small. You get your results in 3 to 60 seconds. They have clocks on them and calendars. One of the things I want to remind you about the clocks and the date, always remember to set the date and the time on your meter, because when you're doing your testing, and if your meter is set for 2014, and when we go to download your meter in the office, we're looking for readings in 2016. Those readings don't show up, and then sometimes you can lose them because a lot of the meters will show the month and the day but not the year. So you can't find the readings because you don't know what year to put in. So always make sure you set the date and time on your meters. They also have memory, and cost is variable. Strips cost about 30 cents to $1 each now. They're also not accurate still. The federal government only requires those meters to be accurate when the blood sugar is greater than 100. They have to be within 20% of what a lab value would be 95% of the time. And if it's under 100, it has to be within 15% of what a lab value is 95% of the time. So it's not going to be accurate anyway, and it only has to be accurate for those ranges 95% of the time. It doesn't make sense to me sometimes. I can't keep up with it. So I work with a doctor. Her name is Dr. Leviton. She is a leading researcher for diabetes. And one of the things she always said is that the pancreas is non-compliant, and that diabetes is the fault of the pancreas, not the person who got this rotten disease. Numbers are your friend. Remember, not too long ago, we didn't have numbers but colors. So she encourages patients to test their blood sugars because it helps them to guide their treatment for diabetes and assess how their meals are affecting their blood sugars. There's also something called continuous glucose monitoring, which is another way to check your blood sugars. Continuous glucose monitoring, you place a disposable sensor underneath the skin, and it is changed about every 3 to 7 days. It's connected to a transmitter and a reader. It checks the blood sugar about every few seconds, and it shows on the reader, it displays a value that's kind of the average of the last readings that were done over the last 30 seconds. One of the great things about continuous glucose monitoring, even though it's not as accurate as a meter reading, what it does, it gives you your trends of reading. You can actually see how your blood sugars are flowing, and you can anticipate what's going to happen, because you might check your blood sugar and it's 90, but because that's testing a blood sugar every 3 to 5 seconds, you can see the trend that it's going to drop soon. And you can also see if it's dropping fast or if it's rising fast. So continuous glucose monitors are pretty interesting devices. They are separate. Over here, you have an insulin pump, which is actually delivering insulin. And over here, you have the insulin sensor. This is checking the blood sugar, and this is delivering insulin. The future holds that these two things will be connected in what we call a closed loop. Right now, it's an open loop. One is doing one thing. You have to tell this what this is doing. So the future, we hope to have a system that's closed so that they can talk to each other without any involvement from the patient. So another really important marker in diabetes history is the A1C. The A1C, unlike the finger stick that you get when you do your blood glucose, is an average of your blood sugars over the last 3 months. It was first recognized in 1958, And a doctor by the name of Dr. Samuel Rabar out of Iran, he first noticed that there was an increase in this number, in this value, in patients who had diabetes. And he was the first person to propose that we use this to monitor the degree of control in patients who had diabetes. There were some other important landmarks that solidified the A1C as the gold standard for overall diabetes control. There was the DCC complication trial. It established that the A1C was a valuable clinical marker. And then again in 1998, the United Kingdom prospective diabetes study confirmed it. So in 2010, finally, the American Diabetes Association recommended that we use the A1C to diagnose diabetes and pre-diabetes. Last slide that I wanted to bring up is just the history of diabetes medicines. As you can see, it's kind of exploded over the years. For a very long time, we only had insulin. And then around 1955, we started to have oral medications introduced to treat diabetes. And it's just been real busy over the last few years, 1985 up until now. There's been a lot of different medications developed to treat diabetes, to include oral medications, working on different ways to control diabetes. There are medicines that work on the liver, because remember we talked about the glycogen stores in the liver, the kidney. Just recently, in the last 2 years, there's a drug been introduced that actually uses the kidneys to get rid of sugar. We know that the kidneys, when you have high sugars, you put out a lot of urine. So there's a drug that's developed that forces more of that sugar into the kidneys for you to get rid of it, to lower your blood sugars. And there's drugs that are developed to work with the stomach. There are hormones in the stomach that help to control blood sugars. There are medications that have been developed to work there. Those hormones are important because they stimulate the release of insulin. They tell the liver to stop making sugar. They also help to make you feel full by sending a message to your brain that you've had enough to eat. So there's a ton of medications out there now to treat diabetes. So there's a lot of options in lieu of a cure for treating diabetes now, but it is very individualized. Well, I guess that's it, guys. Thanks so much for coming tonight. I appreciate it.